My name is Bill Lynch. I'm from Ann Arbor, University of Michigan, and our first speaker is Marcella Sapel from University of Toronto.
Well, thanks so much for the invitation to present. So I'll give a little bit of a perspective on lung transplantation in COVID-related lung disease. These are just some numbers from our own institution. We had our first ECMO case in April 2020, and then by February 2022, we had 182 patients put on ECMO in our institution. And most cases were cannulated there and some another institution and transferred over. Average age 47 and about 3 weeks average time on support. And we transplanted 9 patients out of these 182 patients. So we're very selective in the patients we'll consider for transplantation. This is just to show our ECMO board. We had the time where we had 35 patients at the same time on ECMO in our hospital. This is also a matter of being a centralized system, so pretty much every patient in the province of Ontario, it's 14 million people, would come to our institution for ECMO. So we almost didn't have patients COVID in our CU that didn't require ECMO. Pretty much all of them were the ones that needed ECMO. So I think the criteria used was very similar to most centers. And there are 3 possible outcomes from ECMO COVID ARDS. I think, unfortunately, about 50%, again, this is also statistics and also ours, about 50%, unfortunately, end up dying from complications related to COVID or ICU-related complications. And then you have a subset of patients fortunately recover and survive. And then there is that subset of patients that do not present any lung recovery and basically are stuck with lung failure. And those are the ones that we consider as a bridge to transplant consideration. And in this setting, there are 2 main scenarios. One is the patient on the acute phase of COVID ECMO. They're ECMO dependent and they have to be transplanted off ECMO. And then you have that patient that is just lingering in the hospital with high concentrations of oxygen. And sometimes this patient in a more subacute phase of COVID have to be put on ECMO as a means of rehabilitation support prior to transplant. And so we have patients on those 2 scenarios. The third scenario, which we were most afraid of, was that we'll have this wave of chronic lung disease patients coming like 6 months, 1 year after the disease. And fortunately, we haven't seen those, and most centers haven't seen those. So in terms of the data, the evidence is limited to a series of cases, and there's isolated case reports and some early experience for a multi-center report and also the UNOS registry, but not, of course, a lot of data there. This is one of the largest publications, which did 36 cases of COVID lung transplant, a multi-center study, which was about 12% of all transplants, and included a series of centers from the US and Europe. And what they showed here, the average age was 51. These were, 97% of these patients were supported with VV ECMO prior to transplant. High lung allocation score, all of them bilateral transplants, larger amount of transfusions as expected, and good outcomes in terms of early outcomes, so about 100% 30-day survival in this report, but most of the other reports showed about, somewhat between 90 and 100%. And then 3-month survival, 91%. So this is the other report available, which is UNOS data, 181 patients, mean age 52. 2/3 of these were for ARDS and 1/3 for fibrosis. 9 post-operative deaths, and this accounted 7% of all transplants in the US. This was a span of the year 2021 to early 2022. Now, just showing a few of our cases here. This was our first patient that had this single dual lumen cannula, previously healthy, 64-year-old with COVID disease. You can see his CT scan already showing some chronic changes, bronchiectasis. And this patient, in fact, was cannulated to try some rehabilitation prior to transplantation. He was just on high, oxygen concentrations. And he received a double lung transplant and was weaned from ECMO in the OR, and he went to a rehab 37 days post-transplant. So it's quite remarkable how some of these patients, despite being several months in the ICU, they tend to recover quicker than we used to see the patients with chronic lung disease that were on ECMO prior to transplant. They have a much slower recovery. So it may represent a population that was previously healthy and have that. So we usually do this with a clamshell and central ECMO cannulation. This is the patient after discharged. This is another patient that we put a Protect Duo cannula, and he was also very stable on ECMO for several weeks and didn't present any recovery. Again, some signs of chronic lung disease, not horrible, but he couldn't wean, and also received a double lung transplant, and he was discharged from ICU about 6 days post-transplant. And this is another one that had more severe disease, as you can see here, 48-year-old. ECMO was initiated on February 1st, single organ dysfunction. And you can see here a lot of lung destruction with some bullous disease as well. And he was about 3 months on ECMO and then was transplanted after that. This is how his lungs look like. You can see the combination of fibrosis and bullous disease in that setting. And he's here being discharged from hospital after transplant. I think one of the major challenges here is really when to pull the trigger for transplantation. I don't think we have an answer here. We don't want to do too early, and we don't want to do too late when the patient is no longer possible recovery. And I think the main question we have now is not if transplant can be done for COVID ARDS. I think the main question is when should it be done? And that brings to the question where everyone is familiar here is, can the lung still recover after several weeks on ECMO support? It is of best interest of the patient to come out of the hospital without a transplant if at all possible. And we all have seen situations like that of patient previously healthy, horrible lung disease. This is December 19, and then this is January 9, and this is March 18, and the patient was weaned and went home without any need for oxygen. And so if you had transplanted that young lady, we would cut her expected survival to about 50 to 60% in 5 years, whereas she has a much better outcome at this stage. And the group from Northwestern has shown that many of these patients actually share some common findings related to pulmonary fibrosis, and they did single cell analysis as well and look at some characteristics. And so markers of fibrosis. And so I think, just to finish here, I think the legacy from the COVID transplant is that we should reevaluate our practice for transplantation for ARDS in general. We need to standardize who, when, and how we can consider patients for transplant in acute lung injury. Develop markers of irreversible lung injury. I think this is really a challenge right now because sometimes the radiology doesn't tell the whole story and lungs can suddenly start recovering. And we have to work also on mechanical support systems that, of course, allow long-term support and mobilization. But if we could find markers either in the BAL or even other biological markers that tell us, look, this lung is not going to recover anymore, let's list that patient. I think that would be the ideal scenario. So last slide is, when to consider lung transplantation in COVID ARDS. Generally, age less than 65, single organ dysfunction. We need to give sufficient time for organ recovery. And we never consider transplantation less than 6 weeks someone is on ECMO. Radiological evidence of irreversible lung disease, such as bullous destruction, and the patient should be awake and able to discuss transplantation. Maybe we can talk about this during the discussion phase here. It's a long story to have. Patients should be able to participate in physical rehabilitation. They should fulfill the remaining criteria for lung transplant, and only centers with substantial experience in ECMO bridging should offer this procedure. And you also must have a good access to the broad donor pool and low wait list mortality. Thanks so much for the opportunity.
Well, thank you very much. Impressive, incredible experience. I think this is a nice segue into the next talk, which is going to discuss the concept of bridge to transplant as we're trying to make decisions from afar. So having 35 ECMO patients in your own unit where you can evaluate them and decide if it makes sense for transplant is not our common experience. We're oftentimes getting asked from other hospitals about whether their ECMO patient would be considered. So this should be an exciting discussion. So thank you.
Thank you. Good morning, everybody. Thank you to the organizers for having me here. It's truly an honor. Yeah. There we go. These are my disclosures and funding. None of this is relevant to today's discussion. So I think the big question that I'd like to propose today is, can the bulk of the lung transplant evaluation be performed from afar for patients who are cannulated at other centers and don't recover from their acute illness? And the motivation behind this is we noticed a phenomenon where 2 to 3 months after surges in COVID, our center and other centers would be, there would be a huge onslaught of consults and referrals to assess patients for transplant who just didn't recover from their acute process. We are a center in Tennessee, so we're in the middle of the state. We're the only transplant center for our state, and so we would get consults daily. So this is the month of April that shows that we had close to 30 consults. Most of these patients are young, so less than the age of 50, and most with single organ disease. And so we just didn't have the capacity. Our own hospital had limitations in terms of accepting ECMO patients, so we just had no way to assess these patients. So it really spurred the question, how can we evaluate these patients from afar? And again, these are 2 examples of patients. You can read about their stories on our website. The decision to evaluate somebody for transplant who has not recovered from their acute process really highlights a key principle in ECMO management, which is understand the destination. And I think for the most part, we do a great job in terms of isolating bridge to recovery patients from bridge to transplant patients. But the key question is what happens when your BTR patient just unexpectedly doesn't recover? And how does that impact long-term outcomes? To understand that, I think it's important to really walk through how we select candidates who are bridged to transplant. And this evaluation process really begins in the ambulatory setting. So patients with advanced lung disease present to us, we counsel them for at least an hour. If they want to proceed with transplantation, then they undergo extensive evaluation, which at our center takes about 7 days. Our whole committee then weighs the person's candidacy, and if they're approved, then they're on the wait list. Once on the wait list, if they have an acute decline, then we may choose to offer ambulatory ECMO, but sometimes we don't. So despite that highly curated process, only about 50% of patients that we support on ECMO as a bridge to transplant survive. And this was nicely shown by the Columbia group. This is a series of 120 patients over almost a 9 to 10 year period. And you can see that even in the expert hands of Columbia, survival was only 53%. So then if we're going to perform transplant evaluations on patients who don't have such a curated process, how can we make that evaluation process portable, and how can we distill it and expedite it, but still preserve the integrity of the evaluation? And so here are a few thoughts. So I think one of the first essential elements to preserve of the evaluation is that initial counseling period, where, again, in the outpatient period, we spend about an hour. And during that time, we describe the transplantation process, we describe the pros and cons, we explain side effects and complications of being on lifelong immunosuppression. What we really do is provide an opportunity for patients to say no, and 5 to 10% of the time, they actually do say no if transplant's not right for them. So I think we can actually perform that counseling via telehealth. And I think there's some sayers who say that's not the appropriate platform. Telehealth is meant for return visits, for patients with less acute processes, et cetera, et cetera. But when there are no alternatives, I think it's something that we should embrace. The second element of the transplant evaluation process that needs to be preserved is making sure that people don't have extrapulmonary disease. And the majority of the evaluation is actually radiographic in nature and serologic. And I think that evaluation can be performed by the referring center. The third aspect that's important to preserve is the psychosocial risk assessment. This is actually mandated by UNOS, which is our governing body. Currently, most centers, including our own, have a very subjective process that's non-standardized. But there are tools that people can use. So this is one of them, the PACT assessment tool. It covers 8 different components. Each component is scaled from a score of 0 to 4. And most importantly, this is a validated assessment tool. So using more objective measurements like this can really achieve the task. And then finally, it's most important to assess patient frailty, right? We know over decades now of evidence that frailty really impacts post-transplant outcomes. This is a classic paper from the Duke group that shows that pre-transplant 6-minute walk distance can affect 5-year post-transplant outcomes. And in the BTT population, the Columbia group has shown that the ability to ambulate is one of the best predictors of success post-transplant. Darrell Abrams and folks at Columbia are doing a lot of work to ensure that physical therapy is increasing in frequency and quality in ECMO patients. But I'd like to highlight the fact that even in the expert hands of the folks at Columbia, only 35% of patients undergo active PT. And so when patients are referred to us from other centers, what's the likelihood that they're going to receive PT? And then the other question that I'd like to raise is what form of exercise is adequate to improve outcomes? So most of our patients who haven't recovered from their acute process have been deeply sedated, paralyzed. They're incredibly weak. And so when they start exercising, it's in the form of bed activities like the Leto bike that the gentleman on the left is using. That's clearly not equivalent to ambulation. But the question is it enough? Does it matter in the long term? Should we invest in time and resources to get somebody from point A to point B, or should we just transplant them when they're able to exercise on a bike? I'm not going to cover timing of referral. Marcella did a fantastic job and literally wrote the papers on this. So I will end right there. So to summarize, I think transplant programs need to be flexible in terms of assessing patients, especially those who are cannulated at other centers. There are unique ways, which hopefully I've showed you, to assess somebody's candidacy. But the important reminder is that any deviation from our usual norms should only be done if they don't adversely affect outcomes. All right. Thank you very much.
All right. From UCSF, the Surgical Director of Lung Transplant, Dr. Kukreja. I'm going to speak about bridge to transplant and why optimizing the patient matters.
Good morning, everyone. I would like to thank ELSO and the leadership for the invitation to speak today on RV failure as a bridge to, and its management in a lung transplant candidate. The primary focus is going to be on acutely decompensating RV. I have no disclosures relevant to the talk today. So I'll go over why the RV matters, medical management of a failing RV, and if that fails, how to mechanically support a failing RV as a bridge to transplant. So briefly go over etiology and pathophysiology. So when we're talking about the heart, LV gets all the attention. It's all the larger, more muscular, and the sexier ventricle. But for us in the room, it's all about the inner values. It's about the RV. So all jokes aside, in reality, there's ventricular interdependence. One cannot do without the other. And this is due to the common septum they share between them. And this becomes even more evident in disease states such as pulmonary hypertension, where the afterload increases and strains the RV. So a failing RV literally runs out of steam. It is unable to generate stroke volume, and in advanced cases, frank cardiogenic shock develops. So just like the left side, RV also can have isolated systolic or diastolic failure. In the systolic failure, there's impaired forward flow due to underfilling of the LV, and that leads to malperfusion of the organ and poor oxygenation. In the diastolic heart failure, there's high right-sided filling pressure leading to venous congestion in the tissues, in the periphery, and also in the organs such as edema, ascites, etc. The most common scenario, however, is that of a mixed picture of systolic and diastolic heart failure. I think everybody's seen this slide probably at some point. The etiology of RV failure is diverse. The most common cause is pulmonary hypertension due to heart disease, which is the group 2 PH patients, or the lung disease, which is the group 3. But today, we're just going to focus on group 1, which is the idiopathic pulmonary arterial hypertension, and group 3. So as the pH worsens and the afterload increases, RV remodels. The RV becomes hypertrophied, it dilates, contractility goes down, and the heart failure ensues. Echocardiographically, you can see the thickened RV and RA, and there's flattening of the septum, which makes the LV cavity smaller. There's also TR seen here on this particular image. So when pericardial effusion develops, that's usually a pretty poor prognostic sign. And I don't usually recommend draining the effusion because in a pressure-loaded RV, it is hard to have tamponade because it's hard to collapse that RV. So I would not recommend draining it. All organ systems get affected, but in the ICU, liver, kidney, and gut are the most relevant ones. In fact, malperfusion of the gut can lead to leaky gut syndrome, where endotoxins and bacteria can translocate from the bowel to the circulation, causing SIRS, systemic and inflammatory response syndrome, or sepsis, and these are major contributors to patient death in RV failure. So pH is an independent risk factor for adverse outcome. Even mild elevations in mean pulmonary artery pressures are associated with mortality. In this particular study by Marone, he looked at nearly 22,000 right heart catheterization from VA healthcare system and found that there's an increase of 23% hazard of mortality for mean pulmonary artery pressure of 19 millimeters of mercury. Generally speaking, we talk about 25, but they found in this study 19 millimeter of mercury would lead to increased mortality. Similarly, new evidence also found that mild increases in PVR of 2.2 Wood units, which is a drop in the bucket for us, can also lead to increased mortality. So this is why the RV matters, and this is why it's important to optimize the RV to have better outcomes as a bridge to transplant. So how do we support a failing RV medically? So most of these patients are in the ICU, closely monitored. We do not generally recommend intubating them because induction can lead to full-on cardiopulmonary collapse in these patients. If you can find a trigger, fix it, but in my experience, we never really do. Fluid should be optimized. Common reflex is to give fluids for patients who are hypotensive. But in RV failure, this can be detrimental because if you give more, first of all, a failing RV is never really fluid depleted. And if you give fluid to them, you can make their filling pressures up worse. And as you can see on the right-hand side, the ventricular septum will shift even more towards the left, making the left ventricular cavity even smaller, thereby reducing filling and cardiac output. So in fact, instead of giving volume to these patients, they need diuretics and sometimes even hemofiltration. If a patient is a new referral with a newly diagnosed PAH-directed therapy can be very helpful. But in group 3 patient, this has actually a class 3 recommendation of being harmful. If somebody's already on therapy, it's probably not going to help to add any more agents. And in some cases, despite all the interventions, the RV needs some kick with the inotropic support. My drug of choice is dobutamine. It's what I call the holy water for us. Epinephrine is a second-line agent, but I don't know how many people are experiencing shortage of dobutamine right now. So we don't have dobutamine available, so now epinephrine is getting the limelight. Milrinone, there's not enough data to support milrinone use in group 1 and 3 PH, but there is support for use in group 2 PH. So if the patient deteriorates further on optimal therapy or does not respond to therapy, ECMO remains the only option in select cases. We can use that as a bridge to recovery, which we won't talk about today, but also as a bridge to transplant, or bridge to decision-making to list a patient for transplant. So the timing of ECMO, I think Marcelo talked about it a little bit, too early, too late. In my opinion, when you start talking about this amongst your team members, it's time to do it. Because if you wait too long and you institute this emergently, it does not bode for a very good outcome in this particular patient population. Types of ECMO, everybody in this room knows, VV versus VA. In my opinion, VV in a group 3 patient can be instituted for a short duration, but under those circumstances, you want to monitor the RV closely, serially. And if we're not able to find organs anytime soon, it's not uncommon to get this transition to VA, peripheral VA ECMO. I think most here will agree that for group 1 and 3, VA ECMO is the support of choice. And pumpless membrane oxygenators have also been used from Marcelo's group and from Germany. That's where most of the experience comes from. And Protect Duo, I know he showed a picture of that, but there's really very limited data of Protect Duo use in group 1 and group 3 PH. Most of that data is limited to the group 2 left heart disease-driven right ventricular failure. So peripherally, VA ECMO is the easiest option in acutely deteriorating RV because, as I mentioned, you don't want to intubate these patients. We can do this awake at bedside, open or percutaneous, surgeon choice. There are pros and cons of this. I think everybody in this room knows about those. And central, in my opinion, there are many, many different configurations of how you can do central cannulation, and I think I have practically done every single one of those cannulation strategies. For me, the indications are primarily if you're expecting the patient to be on ECMO for long duration, or if they have small femoral vessels. And also sometimes when they're failing peripheral ECMO, you can switch them to central. Again, pros and cons of that. I'm not going to talk about the upper body because it's, in my opinion, not relevant in an acutely deteriorating patient. This is a list of published data on outcomes of ECMO bridge to transplant, specifically in PAH. And if you look at the third column, there's about approximately 60 to 100% success in bridging these patients successfully to transplant. And if they've been transplanted successfully, there's a 50 to 100% chance of getting them out of the hospital depending on center's experience. There are a couple of studies that have looked at the predictors of outcome in ECMO bridge to transplant, and severe RV dysfunction and kidney dysfunction were found to be independent risk factors for this. So in summary, I think the key is to have early referral before the patient deteriorates. And for the same reason, I think these patients need to be prioritized on the wait list, which they currently are not. And optimizing RV and end organ function can be detrimental to success of bridging someone to transplant. Thank you.
Thank you very much. So we have our last presenter of the day, Dr. Yukita from Nashville, and they're going to talk to us about new frontiers in ECLS for donor organ preservation and recovery.
Hello, I'd like to thank also for this invitation for this talk. So I'll do my best to do an overview of the novel technologies, ECLS technologies to recover organs for transplantation. These are my disclosures. I think the relevant one is the second one. There's a pending patent application for the cross-regulation technology, which I'll talk towards the end of the presentation. So I think everyone in this audience knows that we are short on transplantable lungs. Despite the increasing trend in the number of transplantations done over the years, we've almost doubled it in the last 10 to 15 years. The mortality rate still remains 15 to 20%. And this, in part, has to do with the critical shortage of transplantable lungs due to many lungs getting rejected for injuries, contusion, among many extrinsic factors. And means to improve the transplantable lungs, especially the marginal ones, which are just below the criteria for the transplantation, would increase the supply. And before I talk about ECLS technologies, I think it's worth talking about the current means of cold static storage. The current norm is 4 degrees Celsius, which limits the time of storage or cold ischemia time to 6 to 8 hours, excuse me. But due to the work by the Toronto group mainly, there's been a push towards a 10-degree static storage, which has increased this duration to up to 36 hours. And this may allow for more flexibility in the transplant schedule, transplant surgery time, and this may change the paradigm for lung storage and transport. I think I don't know if I had to say this, but EVLP, pioneered by the Toronto group, has really helped increase the storage time, or the time that the lungs can be kept outside of the body, by incorporating the lung into this closed loop circuit with a membrane oxygenator and a pump. And there's various means that EVLP technologies have been implemented for evaluating those lungs at the marginal quality, also in hopes of improving the lungs that are below the transplant criteria. And as I already said, there's creative ways to increase the time that the lungs can be taken out of the body by cycling between is cold static storage and EVLP. But I think one of the challenges with EVLP is that per run, it's limited to 4 to 6 hours. And this may limit certain types of therapies that could be implemented for the lungs to improve their quality. The EVLP technology can be categorized into 3 different protocols or 4 commercial systems based on what type these system parameters. There's a perfusate, whether it's cellular or acellular, open versus closed left atrium. The OCS, or the organ care system lung, is mobile, so that the lungs can be pumped during transport. And there's various parameters, but I think it depends on what you care about and what target parameters you want to achieve. There's a few options there too. And I already kind of gave you a teaser, but a recent paper by the Toronto group showed that if you combine EVLP with cold static storage, you can really expand on the duration that the lungs could be kept outside of the body. So what they did was they cycled between cold static, EVLP, cold static, EVLP, cold static, and they finished off with a short-term lung transplant model in pig. And they were able to show the viability of a lung, and they hypothesized that it has to do with sort of the maintenance of glucose metabolism, among other factors. And they were able to maintain pulmonary function over this course of 24 hours. I think the caveat here, though, is that this was a healthy lung, and I think there's further evaluation that needs to be done to see if it can improve the injured or marginal quality lungs with this approach. I think another technology that's been on the rise is the normothermic regional perfusion, or NRP, especially with the rise of donation after cardiac death. So this is kind of I think this really fits within the theme of the talk, because this is kind of a modification of existing ECLS or ECMO circuit as a means to, after the patient goes through DCD, you just minimize the period of warm ischemia time by reinstating the blood flow after the declaration of death. And the cannulation strategy is more or less VA ECMO, but depending on where the cannulas are placed, you could provide a thoraco-abdominal perfusion or more specifically abdominal perfusion, depending on which organs you want to procure. And the colleagues at Vanderbilt have been pioneers in this area. They recently published a report, 15 cases of heart transplantation after DCD that then underwent thoraco-abdominal normothermic regional perfusion. And this has expanded the total, I think most importantly, this has expanded the distance that these hearts could be transported. Because before NRP, DCD hearts could only be really procured and transplanted within the center. But this has expanded the distance that these hearts can travel after the DCD. So I'm part of the Laboratory for Organ Regeneration, Recovery, and Replacement at Vanderbilt, and led by Dr. Matthew Bacchetta. And he has been pioneering the use of cross-circulation technology to salvage these organs, mainly lungs, and we've started to work in the livers as well. And we've published a few articles around it, but the concept is not new. It comes from Dr. Walter Lillehei's cross-circulation of providing hemodynamic support for congenital heart patients to be able to do surgeries on them while also providing hemodynamic support from usually the parent, just circulating some of the blood flow through, providing that hemodynamic support while we can operate on the patient's heart. So the hypothesis based on this track record in cross-circulation is that if we can provide this similar type of support, not just hemodynamic, but metabolic and nutritional support, perhaps these injured lungs or rejected lungs or livers or any organs really we could improve or maintain the viability or even improve the function of these organs that may have been deemed unsuitable for transplantation. So this also makes use of existing components for ECMO, ECLS, and create this kind of closed loop, cross-circulation loop between the host and the organ. So this was a multi-day study of cross-circulation, proof of concept to see if this platform can maintain viability for multiple days. So this was an awake swine, and this was an allogeneic cross-circ, meaning it was a healthy swine lung supported with a healthy swine host, or pig bioreactor is what we like to call that. And you kind of see on the right, it's the trajectory of how the lungs look over time at different scales. And we're able to show that the lungs are able to maintain function, maintain cytoarchitecture, maintain normal perfusion over the course of 4 days. And a more recent work in this area was we were able to take rejected human lungs, and use a pig bioreactor to provide support, not only provide support, but improve the function and the anatomy of the lungs. And the pigs were on quite a bit of regimen of immunosuppression, and there's still questions remain to be asked in terms of what are the immunologic implications, the interaction between the pig and the human lungs, and what's the downstream effect of that. We're still trying to get to the bottom of that question, but all this to say, this is a feasible platform. And it's also a much more elongated platform, which would enable other means of therapy and combined therapy and combined interventions. So, we're still, at the very early stage of this development of this platform, but we do think this can provide, alternate path that the lungs could take if they are not suitable for transplantation. Could they be evaluated for EVLP? And then if it fails EVLP, could it be evaluated with cross-circulation platform? And with a longer duration that cross-circ could provide, I think this may also provide opportunities to apply other therapies, gene therapies, protein therapies, immune therapies, to further maybe synergistically improve the function of the lung. But all that sort of in the horizon, hopefully. But thank you for your time, and I'm happy to take any questions at the discussion.
Well, so that was a lot of fun. At least I found it interesting talks, sort of a nice constellation of talks going from clinical practice up through current research and opportunities for the future. So we'll have our 4 speakers up here at the podium, and please come to the microphone and ask questions. I think there might be a lot of questions stimulated. I think just to start, I was going to ask Marcella about how you were able to manage 35 concurrent ECMO patients. How did that impact your ECMO staffing, your nursing psychology, or whatever you want to call it? But that must have been quite a change.
Yeah. We had, prior to that, I think the maximum we had was 13, 14 patients at the same time. So we needed some help from perfusion services from other hospitals that came to support as well. We changed the nursing ratio that used to be 1:1 to 1:2 ECMO patients. A lot of the activities, as many other places, a lot of the activities in the hospital were decreased in volumes and helped to reallocate, people to help and take care of these patients. And of course, our ICU staff also, we used to have 2 ICU staff on call. We moved that to 3 as well at the same time. So I think it was just reallocation of people, basically.
Yeah, no, it's impressive. So we have a question.
Dr. Seipel, you mentioned radiologic evidence to making the decision for lung transplant. So, your slides and also others we've seen this week, you look at CTs at 3 and 4 weeks and you say these lungs are never going to recover. And then you look at CTs, 2 months later and the lungs have actually recovered. So how do you, what's your decision point in making that decision, saying these lungs really aren't going to recover? Because obviously I'm not sure that we know the true answer there.
Yeah. I don't know if we have the answer for that. I think it ends up being a combination of factors. It's not only the radiology, but you have a patient with very poor lung compliance, and that's persistent for several weeks. and you don't see any change in let's say, in tidal volumes over time. And then added to this is the radiological changes showing bronchiectasis or bullous destruction. I think those are the two main ones that we get more worried about. Then, extensive consolidation is not an issue. We see that recovering. But I think still the main point is you need to give time. And so we wouldn't consider transplanting anyone less than 8 to 12 weeks down the road. And I think, we should try to keep these patients as stable as possible. And especially in COVID, it was very difficult to manage them in the first few weeks because they had this very inflammatory phase and, brain was affected as well, and very difficult to wake them up and get them to collaborate with physio and so on. But I think once they pass that phase around 6 weeks or so, 4 to 6 weeks, they become more stable, and I think we could do some rehabilitation on them.
Another question?
Yeah, I'll just build on that. The decision about when to transplant a person with ARDS is an impossible decision. And you have providers who have limited experience in different realms and their own personal biases. And so I guess my question is more to the structure. How do you go about making that decision? As a lung transplant surgeon, you don't have extensive experience managing ARDS. As an ARDS pulmonologist, you don't have extensive experience in transplant. So how do you bring those people together and make sort of the best multidisciplinary discussion about, because as you mentioned, you're not seeing people 6 to 12 months down the road coming in to get transplants. You're seeing fibrosis on a CT that's melted away. So how do you structurally go about making that decision?
Yeah, I'll let others comment here too, but basically the way we did is everyone that was on ECMO for more, between 6 and 8 weeks, we would the transplant team would look at the patient together with the ICU team, and of course, start some preliminary assessment. That doesn't mean that patient is going to be listed and so on, but at least we didn't want to miss opportunities, especially young patients that could be candidates. Again, I don't think we have the answer, and that's why I felt that we need to find markers of lung irreversibility, and I don't think those are there yet. I think maybe will be biological markers in the bronchoalveolar lavage or so on and so forth that may help us to guide that decision. But right now we're still using clinical and radiological assessment at about, somewhere between 2 and 3 months.
Yeah, I think it might be helpful to hear a Nashville approach and a San Francisco approach because it is sort of environment and medical community specific.
Yeah, our approach is fairly similar. Most of the members of our ECMO team are also members of the transplant team. And, whether the person's bridge to recovery or bridge to transplant, a lot of the principles are the same, keeping them awake, making sure they ambulate, good nutrition. So it's helpful for recovery or for transplant. I think our approach has tended to be if they're doing well on support, then let them ride, meaning push the time out to support them. But if they're having complications, then that might be the trigger to transplant them a little bit sooner than later.
I think I don't have anything else to add. It's exactly pretty much the same.
Sure. I mean, I'll say as a transplant surgeon and an intensivist and an ECMO physician, one of the things I find challenging is it also can be emotional. I mean, if that particular patient has a real strong advocate, that can sometimes sway the conversation, whether that's an appropriate way to make decisions. Trying to be subjective about it is challenging, and I think some of the criteria that Marcella sort of described is necessary. You need to have an understanding of what you're going to base your decisions on. So very, fascinating conversation. So, a question?
Thank you very much for sharing valuable experience and data. So patients who are placed on ECMO with an intention for lung transplant, some patients do well, some patients don't. And, we are all interested in, what kind of good prognostic factors before we place them on ECMO. And the questions for you is that in our program, when they don't do well, a common mode of failure is that patient who is listed comes in for acute deterioration, they get intubated, and then, okay, so why don't we place her on the ECMO? And then, even though they get on ECMO, they don't get extubated, oxygenation is not very good, they don't seem to be responding very well to VV ECMO, and then we do a cardiogram. RV seems to be okay. And then a patient continues to decondition, and then they may lose timing of transplant. You might have encountered a similar situation, but what would you do for those patients?
So Amy, do you want to comment, and then we can work our way down the row? I know each of us are going to have a different sort of answer, I bet.
It's okay. I'll pass on that one.
Oh,
Sorry.
okay, good.
Well, I think the biggest thing is avoiding that cycle, and it starts with intubation. So at our center, we avoid the endotracheal tube as much as possible. So the patients are supported on high-flow nasal cannula and until they can't be supported. And then at that point, we just put them straight on ECMO. So I think that's really key, is keeping them awake, keeping them ambulating. And the moment you have to intubate them, then it's that vicious cycle of deep sedation, paralysis, sort of the death spiral.
And I think at our program at Michigan, there's a difference between a patient who has not been evaluated for transplant versus somebody that's already been evaluated and is maybe active on the list. I think for the patient that's not been evaluated, making sure that everybody, which is usually the patient's family and the nurses, understand what the thought process is. A lot of times it's support to decision making, and the chances of that patient progressing to transplant is usually small, so you need to make sure people realize that there's also a chance that we'll just withdraw support at some time. So,
Bill, if I can just comment,
Sure.
It's more related to the previous question, when to do when the time to pull the trigger and so on. But I also think we need to look at the data of the ARDS patients that are on ECMO for 3-4 months, 5 months, and eventually get decannulated. How are these people doing at 1 year? To put that in contrast with the transplant patients, we know the transplant patients, most of them are doing well at 1 year after transplant. In that setting that we talked about, get your transplant, between 2 and 3 months, being on ECMO, you feel it's not going to recover. Because we tend to say, well, transplant may be really a bad scenario, but what is the comparison for that? Is keeping that patient additional 3 months in the ICU rather than, these patients you transplant, they are out of the ICU in 2 weeks, okay? Keeping that patient in the ICU another 3-4 months to get them decannulated. How are these people at 1 year? I think Ankit looked at that at Northwestern data, and those people are not doing well.
okay.
So I think that's another thing to look at.
Yeah, fascinating. So, question?
Yeah, I had a question for the Vanderbilt group. Really enjoyed your talk, and I wanted to ask a little bit about this concept of using an animal for organ preservation, or a bioreactor, as you called it. Could you just talk a little bit about the potential for infectious complications, and more specifically, any processes that you might have to mitigate the risk for transmission of, infectious diseases, especially given some of the recent events with the porcine xenotransplantation and so on? And is that going to be an issue for approval in the long term? Thanks.
Yeah, thanks for the question. I think that's an ongoing concern when we mix species, like we do in our case. As much as as great as the durability may be for cross circulation, we don't quite know what are the long-term risks of having a pig system mixed with a human lungs. So some of the stuff we're currently working on is characterizing the deposition of immune cells and the types of immune cells that are present in, say, lung tissues after 6 hours, 12 hours, 24 hours of cross circulations. we're hoping based on the data that we see in like immunocharacterization, well, not just leukocytes, but any immune components, and figuring out if we could titrate or optimize the immunosuppression or use of some filters to filter out unwanted antibodies or cells to further improve our platform and just minimize these potential risks of zoonotic infections and immune response from the pig.
I mean, I think what is true is we're starting to realize that we can manage organs for periods of time, which I think is going to change not just simply the logistics of transplant, but the ability to modify organs down the road, the opportunity to increase the donor pool to offer transplants to more people. I mean, that I think is what the future is. So it's exciting to see it coming to fruition. So I think we have time for maybe a couple more questions. So.
Enrique Gongora from UAB. We have a large ECMO program and a transplant program, and we've had a big cohort of patients with COVID-19 already over 110, and we did look at our survival as time goes by on a month-to-month basis, and we are up to 5 months, and we have encountered at each month a 50% survival on those patients. I wanted to know what the panel's experience on that has been, and how that would influence down the road the timing for transplant selection. Even though 120 patients, COVID patients, sounds like a lot, in the big scheme of things, it's not that much. And I think we need to aggregate all our collective COVID experience and extrapolate to see if those patients would equal the patients with ARDS that were non-COVID, to see how we could really find out what the trigger is to pull the trigger for transplantation. So, what's the experience with long-term COVID and their survival at different time points?
So in terms of, they're long-term COVID on ECMO still?
ECMO, exactly, on ECMO, and then just keep them on ECMO. And
I think our experience is limited, but probably similar to yours, right? So it just really depends on the patient and what complications they face. And it's really those who, we've had circuit failures, infections. I mean, your group just transplanted the girl I showed, right? So 9 months on ECMO, one complication after another. We deemed that she wasn't going to be a transplant candidate because some of the infections that she harbored. But she persisted, and we persisted, and ultimately your group transplanted her. So I think there's going to be case-by-case variability. I think sometimes it's just a little bit of good luck, but and good critical care management. So I don't have much more of an answer than that.
I have 2 that have been in the hospital a year now since their COVID infection. Both spent 7-8 months on ECMO. Both eventually came off ECMO. One is still on about 50% oxygen, but she ambulates, she talks, she walks around. The other had more severe fibrosis, and now he probably will die this week, after a year in the hospital, but was able to come off ECMO, but just never recovered his lung function. And unfortunately, they're at a county hospital where they don't have access to transplant. And that's, one of the downsides of the U.S. healthcare still, that we can't give equal care to everyone.
Right now, we have somebody that is the longest, I think, lung transplant for after COVID. That's been 9 months for us. We have somebody waiting for a year. Now it's in a hard lung because he's got an RVAD, and he's still got right ventricular failure despite having the RVAD. So we'll see how that goes.
No, thank you for that. I mean, it's clear that this is a long-haul game. I mean, it's very different than a decade ago when we were managing patients with either acute lung injury or in preparation for transplant. So very different. Another question.
Hi, I'm Bob Bartlett. Just 3 comments. First of all, what a great session. Thanks to all of you. Thanks to what you're doing for patients based on stuff we've done for many years now. So really exciting. 3 comments. One is just relating to the paracorporeal pig. So someone asked about it. We've been doing this for several years, and using hearts, but it's the same concept. So when you have a heart attached to a paracorporeal animal, and it works, it really does work great for days, you're adding something and you're removing something that the pig deals with. So what we've learned is the removing part of it is solved by hemofiltration. So whatever we're removing is less than about 50,000 kD, and so the removing part is simply solved by hemofiltration. On the addition side, what we've learned is you can just use plasma of an animal of the same species, including humans, and just use plasma. It has the magic stuff in it. We're working on what's the magic stuff, but the paracorporeal animal is great for experimentation, all kinds of things you can learn, but we're beyond that now. We can do this all by essentially plasma exchange with hemofiltration. The second point is that where I see we're pushing in clinical ECMO is interesting, because we've all heard about these patients. They've been on for 6 months, 8 months, a year and a half, and so on. They're all in the ICU. So my push is, why is that? Those patients are so stable. We really need to get working on getting them out of the ICU into step-down units and home. And you think you're going to do that with ECMO? Hey, it's what we did with VADs, for Pete's sake. Some of you might remember a VAD patient would be in the ICU for a year waiting for a donor. We don't do that anymore. And the devices are available. It just needs some people to bite the bullet. You guys are the right ones to say, okay, enough of that. We're going to take this patient into a step-down unit eventually, get him home. And then finally, this from my point of view, I mean, this is just fascinating to hear, because all of this discussion about when to take it, they're going to get better to transplant. These are all people on chronic ECMO. Could you believe this? People on chronic ECMO with acute infectious disease. 5 years ago, nobody would have this conversation. So stimulated to some extent by COVID. So thank you for doing it. It's really exciting to see.
Well, I think we'll have to conclude this session now. Wonderful session. If you have questions and you wanted to come up to the table, please ask the group up here. But appreciate the attention and enjoy the next session. Thank you so much.
Thank you, everyone.